Hello,
Yeah, hello, sir.
madam has also joined. Radhika madam, can we start, madam?
I think we will start.
10 are there, okay. So, good evening all. Uh, this time we are presenting a case and this is being moderated by Dr. Sivakumar sir. Sir is the professor and head of the Department of Pediatric Surgery, SAT Hospital, Government Medical College, Trivandrum. And the case is being presented by Dr. Gowri, who is our senior resident at SAT Hospital, Trivandrum. So over to Gowri to start the presentation.
Good evening, everyone. Am I audible, sir?
Yes,
Yes.
audible.
So, today we are going to present a case, the great imposter, right-sided congenital diaphragmatic hernia camouflaging as hypoplastic left heart syndrome. So, our baby was an early term, 37-weeker, 3.21 kg, large for gestational age baby, born to a 29-year-old primi gravida, born out of non-consanguineous marriage, with maternal comorbidities being overt diabetes mellitus on insulin and pregnancy-induced hypertension. Her second trimester anomaly scan revealed hypoplastic left heart with small aortic isthmus, and the fetal echo done was suggestive of borderline LV and aortic hypoplasia, dilated RA, RV appendage, which was not duct dependent. So we were planning to evaluate her postnatally. And baby was a female baby and had mild perinatal depression, required positive pressure ventilation for about 30 seconds. And at birth, baby had respiratory distress, tachypnea, retractions, and occasional grunting. Cyanosis was there, and saturation in room air was 84%, with Downey score at admission 4. Air entry at admission was slightly reduced in right side, and transillumination was there was no evidence of pneumothorax. Cardiovascular system examination, all peripheral pulses were palpable, no hypotension, no murmur. We started the baby on non-invasive ventilation support. So our primary impression was that baby was having a cyanotic heart disease. Hence, we proceeded with cardiology evaluation, and bedside echo done at 2 hours of life by our pediatric cardiologist revealed a large PDA, severe PAH with suspected and also suspected that all 4 pulmonary veins were forming a common chamber posterior to left atrium and draining to the roof of right atrium, and we were about to rule out cardiac TAPVC. Just then, the X-ray taken came to our NICU and it revealed a large right-sided homogeneous opacity with minimal left-sided mediastinal shift and liver being absent in its normal position. So our differential diagnosis at this point of time was right-sided CDH, and we proceeded with the bedside ultrasound lung. And it revealed this in right hemithorax, instead of lung, we were seeing the hepatic tissue. Here you can see the hepatic parenchyma instead of the normal lung parenchyma. So to confirm our diagnosis, we did a CT thorax, which showed right-sided congenital diaphragmatic hernia with right lobe of liver in right hemithorax with only partially aerated apical segment of right upper lobe and mild mediastinal shift to left. There was gross hypoplasia of right lung with tiny thread-like right pulmonary artery and non-visualized pulmonary veins. Dilated RA, RV, and MPA, a large PD of 7 mm, and there was no TAPVs as we suspected previously. So we were dealing with a right-sided CDH, which mimicked HLH in antenatal USG. So as we can see, associated anomalies in CDH is having a high impact on prognosis and outcome. And among the associated anomalies, 24% of are cardiac, and cardiac hypoplasia of left side of heart mimicking HLHs is a common association, just as we see in the previous case. Coming to the prenatal diagnosis, about 50 to 70% of CDH cases are diagnosed antenatally, usually in the second trimester USGs. And the fetal ultrasound features suggestive of CDH are polyhydramnios, intrathoracic stomach, that is in fetal USGs, usually only one bubble will be visible, that is of heart. If we are seeing two bubbles in thorax, that is heart and one stomach, we should suspect CDH. And also mediastinal or cardiac shift in case of left-sided CDH. And in right-sided CDH, we can see that right lobe of liver usually herniates to thorax. So measurement of disease severity by fetal ultrasound. These are the common parameters: three-dimensional estimation of fetal lung volume, right lung area to thoracic ratio, lung to thoracic circumference ratio, and lung to head ratio, which is the most widely used prognostic indicator. Now coming to lung to head ratio, it is lung area divided by head circumference, and lung area calculated is of lung contralateral to the side of CDH. So if it is less than 1, it indicates a poor prognosis. There is a 2023 update by Canadian CDH collaboration regarding the sonographic predictors. Intrathoracic liver herniation is a bad prognostic marker. It has also mentioned stomach position classification, which needs more evidence, but there is a parameter observed to expected lung to head ratio. That is, between 12 to 32 weeks, there is a 16-fold increase in fetal lung and there is a 4-fold increase in head circumference. So there is a differential growth. Hence, this ratio is used between 22 and 32 weeks of gestational age. So, observed to expected lung head ratio, if it is less than 25% in left-sided CDH, we should classify it as severe pulmonary hypoplasia. And between 26 to 34% in left, it is suggestive of moderate pulmonary hypoplasia. And if it is less than 50% in right-sided CDH, it is suggestive of severe pulmonary hypoplasia in case of right CDH. Coming to fetal MRI as a prognostic marker, total fetal lung volume and quantification of liver herniation are used to assess disease severity, ideally at 26 weeks. So, if it is total fetal lung volume less than 35% and liver herniation are significant predictors of mortality. Now, MRI parameters are more reproducible. They perform better with greater sensitivity and specificity for survival prediction. But MRI is usually used for prenatal prognostication, even though ultrasound assessment is likely to remain the cornerstone of antenatal prognostication due to its widespread availability. So, why CDH may be missed antenatally, just as in our case? It may be due to intermittent herniation of abdominal viscera into the thoracic cavity. And when the stomach is in a normal abdominal position, herniated small bowel loops, which are fluid filled in a fetus, are not easily distinguishable from the lung parenchyma. And the misinterpretation of the fetal ultrasound scan can be caused by other diagnoses such as cystic lung anomalies. And in right-sided CDH, on prenatal ultrasounds, liver and lung are having similar echogenicity. And also, liver, when herniated, can obscure the visualization of small hernial defects also. So, in all affected pregnancies which are diagnosed to have CDH, they have to be offered invasive genetic testing with chromosomal microarray analysis. There is a 10 to 13% risk of CMA abnormality in isolated CDH, and expanded genomic analysis like exon sequencing will likely increase this diagnostic yield. So coming back to our case, on day 4 of life, our baby was in NIV support with an FiO2 requirement of 30%. Her urine output was 2 ml per kg per hour. Pre-ductal saturation was 90%. Repeat echo revealed mild pH and her NIBP was normal for her gestation age. So, baby was taken up for surgery on day 5 of life. At this point, we are coming to the timing of surgery 2023 updates. Following criteria should be met prior to the surgery. That is, urine output more than 1 ml per kg per hour, FiO2 requirement less than 50%, pre-ductal oxygen saturation between 85 to 95%, normal mean arterial pressure for gestational age, lactate less than 3 millimoles per liter, and estimated pulmonary artery pressures less than systemic. Canadian guidelines have also mentioned the use of oxygenation index as a proxy for physiological stability in CDH. OI in first 24 hours of life less than 9.4 correlated better with survival of babies. So, and surgery should be reconsidered if a patient fails to meet the surgical readiness criteria after 2 weeks. And in patients who have achieved physiological stability, there is no benefit in delaying operative repair further. Now, surgical repair of C dish, it can be open repair, laparotomy, thoracoscopic repair, and laparoscopic repair options are available. Advantages of laparotomy are viscera can be reduced easily, can mobilize posterior rim of diaphragm, and can manage malrotation if present. And the update on laparoscopic CDH repair tells that recurrence rates for minimally invasive repairs of CDH continue to be higher than open repairs, and minimally invasive repair may be considered in patients who easily achieve preoperative ventilatory targets with infrasystemic pulmonary artery pressures and normal cardiac function, and if the neonatal and surgical team is technically proficient and is ready to proceed. Patch repairs are done in large defects, and the options are synthetic patches, biosynthetic patches, and autologous tissue patches. And a new recommendation of oblique muscle flap repair may be considered in some cases. And for pain relief, all infants with CDH requiring mechanical ventilation should have personalized analgesic or sedation management, and intravenous opioid should be administered in combination with the short-acting benzodiazepine. And routine neuromuscular blockade should be avoided in pre-operative stabilization. And post-operative, we can use intravenous acetaminophen for pain relief. So for our baby, a laparotomy with right CDH mesh repair was done. And the intraoperative findings were a very large defect in right hemidiaphragm with defect more than 50% of right diaphragm. An entire right lobe of liver in right hemithorax, dense adhesion of liver to right hemithorax at the medial aspect. Hence, liver couldn't be mobilized medially. The right lung was severely hypoplastic without any expansion, and defect could not be closed primarily, hence proceeded with a Prolene mesh repair. So this is the post-operative period timeline. On post-operative day 1, baby was mechanically ventilated, and USG lung on post-operative day 2 revealed liver was seen till right hemithorax up to nipple line, and we started baby on IV antibiotics initially. On post-operative day 4, we extubated baby to NIV and started on feeds and added Domstol also. So, while mechanically ventilating a baby with CDH, we have to consider these properties. That is, usually in CDH, babies will be having a short trachea. So, the length we usually calculate as 5.5 plus weight, and we have to avoid right mainstem intubation also. So, the upper airway will usually be compliant and contributing to the dead space. They will have pulmonary hypertension, increased lower airway reactivity, mediastinal shift, and right ventricular and left ventricular dysfunction, and herniated intestines also in the thorax. So, the approach is gentle ventilation with permissive hypercapnia and tolerable hypoxemia without hypoxia. So, the initial settings that we usually keep in conventional ventilation are a tidal volume of 4 to 5 ml per kg, a PIP maximum of 25 millimeters, and PEEP 3 to 5 centimeters, and respiratory rate 40 to 60 per minute. So this is a pressure volume graph showing the relation between compliance and the pressure in CDH. So in diseases like RDS, where there is PPHN due to parenchymal lung disease, when we increase pressures, the compliance of lung may increase to a point. But in CDH, both the lungs are already hypoplastic. So if we increase a PIP below pressures beyond a point, it can only lead to air leaks rather than increasing the compliance. So our goals are to keep the preductal saturation between 92 to 98%, and saturation more than 90% is tolerated. PaO2 between 50 to 70 with tolerated PaO2 more than 45. PaCO2 45 to 55 with tolerated PaCO2 less than 65 millimeters of mercury, and the X-ray chest showing 8 to 9 rib inflation of contralateral lung. High frequency oscillator ventilation, it helps to avoid ventilator-induced lung injury, It is used as a rescue therapy in infants with profound hypoxia and refractory hypercapnia and can be used if PIP exceeds 25 centimeters of water. And routine GERD may persist in more than 60% of babies post-operatively, especially if the GE junction was in the thorax. So routine preventive fundoplication is not advised at the time of CDH repair. It is done only if medical management fails. So coming back to our baby, on post-operative day 4, baby was weaned off to NIV. On post-operative day 10, we tried HFNC trial, but it failed and baby was continued in NIV. X-ray right side showed increasing haziness and a repeat USG revealed right liver was still till the nipple line. And echo revealed a 4 mm PDA, moderate pH, and FiO2 requirement of 30%, and hence we added on sildenafil. On postoperative day 14, baby was still on NIV support, and USG showed a liver seen superiorly displaced in right lung, with lung sliding only in few superior-most aspect of right hemithorax. And echo, repeat echo, again revealed severe PAH, hence we had to add tab bosentan. So, fixed and intractable pulmonary hypertension is a hallmark of CDH. It is mainly due to the reduction in total number of arterial branches on both sides, abnormal muscularization of small preacinar and intraacinar arterioles with wall thickening, and increased adventitious thickening of pulmonary veins can be seen secondary to pulmonary hypertension. So, this is the two-hit hypothesis of pulmonary artery hypertension in CDH. Initial hit, that is the embryological factors leading to bilateral lung hypoplasia, and second hit during the embryological period when the herniated abdominal contents compress the ipsilateral lung. Both these factors leads to pulmonary arterial hypertension in CDH. So normally when child breathes spontaneously, pulmonary artery pressures fall, allowing increased pulmonary blood flow. Systemic and left atrial pressure rises, closing the foramen ovale, and increased arterial oxygen tension leads to spontaneous closure of ductus arteriosus. But the vicious cycle of pulmonary hypertension in CDH is that high pulmonary artery pressures leads to decreased pulmonary flow and increased vascular resistance, leading to a right to left shunting at the ductal level, unsaturated blood in systemic circulation, and this blood returning to the right side. So the resulting hypoxia and increasing PAH will further worsen the situation, and acidosis, hypothermia, stress, alteration in levels of prostaglandin, leukotrienes, and catecholamines can further aggravate PAH in postoperative period. Now, the sildenafil we used in this case is a PDE5 inhibitor. It leads to pulmonary artery smooth muscle relaxation, improves precapillary pulmonary venous return, and reduces systemic vascular resistance. Now, it may exacerbate ventilation perfusion mismatch if there is excessive pulmonary vasodilation. Oral sildenafil can be used as an adjunct in weaning, other vasodilators, and in chronic postoperative PAH. So, it can also be used in refractive PAH unresponsive to INO. Now, bosentan, many studies have shown overexpression of endothelin 1 and endothelin receptor A in CDH. So, bosentan is a dual endothelin receptor antagonist with more affinity to endothelin A receptor, which leads to vasoconstriction and smooth muscle proliferation in pulmonary arteries. Shortly about inhaled nitric oxide. Acute persistent pulmonary hypertension. It can be used in acute persistent pulmonary hypertension in near term and term neonates. Endogenous NO pathway. It acts via the endogenous NO pathway, stimulates CGMP in pulmonary arterial smooth muscles, leading to relaxation and vasodilation, reducing the pulmonary vascular resistance. It improves ventilation perfusion mismatch by increasing the blood flow. It forms methemoglobin, and by that it improves oxygen delivery to tissues. RCTs have not demonstrated any benefit, but in selective INO use may be considered in high respiratory and oxygen requirements when clinical phenotype is suggestive of precapillary vasoconstriction. So if echo is showing suprasystemic pH in the absence of left ventricular dysfunction, and if lung recruitment is adequate, a trial of INO can be given. And if there is no demonstrable echocardiographic or clinical improvement, INO must be stopped. So these were the serial X-rays that we took for our baby, showing worsening right-sided haziness. On postnatal day 17, the distress worsened. Baby was intubated, initially kept in SINV for few hours, and as distress worsened, the support was upgraded to HFOV. Baby was given PRBC transfusion, started on adrenaline infusion, but baby continued to deteriorate. And despite of all our efforts, baby passed away on postnatal day 22 on postoperative day 18. So what are the reasons for poor outcome in right CDH? So the diagram on the right side shows classification of CDH based on the size of the defect. And as you can see, defect C and defect D, when the defect is occupying more than 50% of the hemi diaphragm, there are higher proportion of large size defects in right-sided CDH. And there is no pleuroperitoneal sac around the herniated liver usually, leading to injury to the lung on that side. And there is more compression to heart and lung by the sordid liver, leading to more chance of severe lung hypoplasia and severe pulmonary arterial hypertension in right-sided CDH. Coming to associated anomalies in right CDH, the common ones described in literature are hepatopulmonary fusion, intrathoracic kidney, and associated vascular anomalies. Coming to hepatopulmonary fusion, herniated liver becomes densely adherent to or fused with the underdeveloped right lung tissue. Incidence is 3 per 1000 CDH cases with a mortality rate of 50%. The spectrum of hepatopulmonary fusion ranges from fibrovascular communication to parenchymal fusion. The embryological basis for its development are failure of formation of diaphragm during early gestation, allowing hepatic tissue to herniate into chest and fusing with lung, and as a primary anomaly, interfering with diaphragm development also. So it should be suspected when there is opacification of right hemithorax without a mediastinal shift to contralateral side, perhaps due to the severely hypoplastic lung in the right side. Shift may be there if bowel also herniates. So USGs show liver in thorax, gallbladder will be above the diaphragm, and Doppler will reveal an umbilical segment of portal vein bowing towards the left and lateral segment of left hepatic lobe in the direction or above diaphragm. The hepatic veins directly draining to right atrium is a significant clue in echocardiographic evaluation, and demonstration of venous drainage from lung parenchyma into intrahepatic part of IVC may also be a diagnostic indicator of hepatopulmonary fusion. The investigation of choice is MRI. The surgical procedures described are separation of lungs and liver with repair of defect around fused organs without separation, and even partial hepatectomy or pneumonectomy. Complications of hepatopulmonary fusion are right heart failure and thrombosis of IVC. So this is an X-ray showing right-sided CDH.
Gowri, you want Sivakumar sir to take over the session? Hello?
Yeah, yes. Gowri, have you finished?
Yes, sir.
You have finished, right. Can you show the much more pictures I have sent you, or
Sir.
just go through the pictures? Yeah.
Sir.
Any issue in showing slides, or should we go on to the 9:30 section, or
Sir, 10 minutes more is there.
is there? Yeah, right.
Ah,
Just go through the pictures, then I will start
okay, sir.
talking something.
Sir, right-sided CDH with agenesis of lung. Fingering defect. Right-sided CDH with hourglass defect. CDH repair in progress. Photo showing CDH sac. X-ray AP view showing right-sided CDH.
I think I will explain. Sorry, I think sir will.
Ma'am, shall we start with the second meeting time then?
I think this
I think
goes continue. One only.
it is nearly 9:30. We'll go to the next
Okay, sir.
session. Yeah, we'll go. Right.